Hello, everyone, and welcome to another ECG of the week. Let's kick things off this week by taking another look at our clinical vignette and refamiliarizing ourselves with this week's case. And let's have a look at the ECG. So, you know what I'm going to say. Go to your 6-step method. So let's start by trying to determine the rate of this ECG. So we will kind of zoom in a little bit and let's try and find a good R peak, perhaps this one, and we will use this second one. And those ones are pretty nice. You can see, and we're going to use the 300 method just for the record. And let's count the boxes in between the two R peaks. You've got 2. So we're doing the 300 method. 300 divided by 2 is 150 beats per minute. So that is the rate. Nice and easy, quick. We're getting quicker and quicker each week. Next thing to do is look at our rhythm. So if we start with the first R peak, the second and the third, we're going to use the same trick we use just by moving those 3 dots along just to see if things line up. And it's looking like they line up pretty nicely across all of the peaks there. So we've got a regular rhythm. Next thing we do is look for our P waves and just to see if they are present, and you can see across the ECG, I'm marking them here. You've got P waves there. And of course, the second thing that we look for is P waves that are followed by QRS complexes, which you can see as well in every, with every P wave, there's a QRS that follows it. So that's a nice normal finding there for our P waves. And the P wave morphology also looks normal. So that's it for P waves. Moving on to our QRS complexes. So we've got an interesting finding here. So we do have what looks like narrow QRS complexes. The quality isn't great, but this looks to be just about one small box. We'll use a different size there. This looks about to be one small box. This one as well looks about to be one small box. Like one to two, a little bit more than one small box, that is. And so that's within our normal QRS complex. Remember, we're looking for QRS complexes that are less than 120 milliseconds or 3 small boxes. So we have nice narrow complex QRS complexes, but of course we're looking at the kind of this finding that you're seeing kind of in these pairs where one of them is short and one of them is taller, and that seems to be repeating across the entire ECG. So keep that in mind as we kind of continue with our 6-step method. But for what we know so far, that's a normal narrow QRS complex, so you know that our conduction pathway is coming from the SA node from the upper chambers and then going the supraventricular chambers and then going down into the ventricles. Next thing we're looking for is our PR interval. We'll just keep using the same kind of, this one's actually pretty good, landing right on the line there. And then we're going to, hard to count, but you can say 1, 2, 3, and then you're hitting your Q wave there, which is pretty good. So 3 small boxes there is great for a PR interval. We're looking for less than 5 small boxes, so that's putting us at a PR interval that is approximately 160 milliseconds. There you go, which is great because we're looking for less than 200 milliseconds, which is 5 small boxes. And well, that's not right math. If it was 3 small boxes, then each box is 0.4, so it would be like 120 milliseconds, which is grand. That's grand, and it's hard to tell really. It might be 4. No, it's probably 3. Okay, we'll stick with that, which is fine. We're still just looking for less than 200 milliseconds, so that is well within our range there for PR interval. And last but not least, just looking kind of more globally at the ECG, I'm using the rhythm strip right now, is just to see if there's any kind of changes in our ST segment. And, it looks, it looks a little strange than you'd expect, but there is no, like for instance, there's an ST segment in V1, V2 has a nicer picture, and same with V3, and you really are seeing this return to the isoelectric line after the S wave before the T wave comes in, and that's really what we're looking for with our ST segment. Same thing in V4, V5, V6, and then looking over here at our limb leads, there doesn't seem to be any kind of ST elevation or ST depression. So there are some minor changes, but nothing specific that we have to be worried about. So that kind of wraps up our 6-step methods for this ECG. So what are we talking about? Like, let's go back and just review. We said our rate was about 150 using the 300 method. So we're looking at, a little bit shorter than that. I'd say 145 beats per minute, but we were in the right ballpark. This is at 145 beats per minute, this is a tachycardia. Remember, because our normal rate is between 60 to 100. So anything above 100 is going to be tachycardia. And we said that those rhythms were lining up. All of our R peaks were lining up. So this is an example of a sinus tachycardia. Our P waves were present. They have a normal voltage and normal morphology, all followed by QRS complexes. Our QRS complexes were nice and narrow, less than that 120 milliseconds that we're looking for. And our PR interval somewhere between like 120 and 160 milliseconds, which is great for PR interval. We're looking for less than 200 milliseconds, so that's normal. And then the ST segment, looking back kind of at the whole ECG, there were no kind of gross changes in the ST segment that would indicate that indicated depression or elevation. So there are some minor non-specific changes there, but that it's not something that we're super concerned about. So the question I guess of the hour is, what is this ECG? I will just take you back here, and I think really what to zoom in on is these kind of this alternating pattern of like low QRS, tall QRS, low QRS, tall QRS, low QRS, tall QRS. And if you go back to your history, this is a woman who's kind of been having non-specific chest pain, but was brought in with a BP of 90/60 and in sinus with a pulse of 130 and with jugular venous distension. So all of those together kind of paint a picture of what our case this week is. And with our finding, we're looking at a tachycardia with electrical alternates, is specifically in V1 and V2, and that's what this finding kind of looks like. It's the alternating V1, V2. It's the alternating size of the QRS complexes with each beat. Usually our QRS complexes have the same amplitude every time, but this is kind of like a low amplitude, high amplitude, low amplitude, high amplitude. And that is also indicative of our diagnosis, which is cardiac tamponade. So what is cardiac tamponade? Cardiac tamponade is a particular emergency where any fluid buildup in the pericardium, whether it be a pericardial effusion or if it's blood that fills the pericardium from a left ventricular free wall rupture, can build up. And because your pericardium is fixed and the heart sits inside of it, it is as the fluid begins to build up and cannot escape, it actually compresses the heart. And that's like what we call cardiac tamponade, is the actual compression of the heart due to fluid buildup. And so, like I said before, the identifying factors, our clinical identifying factors are called Beck's triad. So that's hypotension with distant or muffled heart sound and raised jugular venous pressure. And that raised JVP is just due to your the actual effusion pushing on the right ventricle on the right side of the heart and causing the backup of that blood back up into the venous system. And what happened, this was mentioned in our case, but what happens in the tamponade is those are really good key features, but really you need an echocardiogram to confirm this particular finding. The electric alternans are another good clinical clue. Once you do an ECG, if you see that kind of like alternating amplitude in your QRS complexes, that's what the electrical alternans are, and that's what this is showing here. And what are the electrical alternans actually caused by, if you will? Well, if your effusion is blood or fluid, as your heart beats, it's actually swinging back and forth amongst the fluid, and so the amplitude changes in your QRS complex are actually due to the swinging with each beat, the swinging movement of the heart with each beat, and like that within the effusion, and that's what's causing that particular finding on the ECG. And here we just have like an example image of a echo that's showing you like your heart here, right? And then your right and left sides, and all of this dark stuff kind of around the outside of that is all effusion, 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 all of this black. This is it's cut off here, but like imagine like your pericardium continues like this, and all of this is the pericardium. This is the pericardium out here, and all of this in the middle is effusion. So that's all fluid buildup, which can be, again, pericardial effusion. It can be due to ventricular wall rupture, and so it could be blood filling the pericardium. But either way, massive effusions can cause the compression of the heart, and that's where you kind of get into the emergency. So what can cause a tamponade? So renal failure, malignant effusions, inflammation. You can get it post-MI, again, if you have an MI and there's necrotic heart muscle and it ruptures, then that's going to open up a little space for blood to leak out of the heart and into the pericardium. There could be iatrogenic causes, so patients that are getting stents placed or getting some other minimally invasive cardiac investigations, that's all right. Interventions can cause an effusion, and then any penetrating trauma as well can cause an effusion. So those are just some examples of what can cause an effusion, and also parts of your history to look out for, if you're considering an effusion perhaps. And what is the pathophysiology? This is more pathophysiology. So there are a lot of, especially if you're taking board exams, a lot of times they will mention STEMI as a antecedent to a pericardial effusion or an antecedent to a free wall rupture. And funny enough, that's not as common anymore, but it doesn't mean it can't happen. So any kind of injury, like we said before, that's going to damage the heart muscle or cause a puncture or cause fluid to build up in the pericardium, all of that can cause a pericardial effusion. So we just are trying to keep it within. Give you an example here by saying, if you were to have a STEMI, especially with a late presentation like our case this week, that STEMI could progress to if there was enough of an infarct to the heart muscle and enough necrosis there, like you could get a ventricular free wall rupture, and that could definitely lead into your tamponade. So other things like causes of ST elevation, which is your STEMI finding, plaque rupture. There's also cocaine-induced myocardial infarction. You've got spontaneous coronary artery dissection, like anything that's going to damage the coronary arteries and decrease blood supply to the heart itself is what we're looking at. Pericarditis, Takotsubo, early repolarization. So these are just, again, things to look out clinically and in your history when you're looking at the ECGs or when you kind of are looking at things. So just remember, ECG is just one part of your clinical toolkit. You need to do a history, you need to do a physical exam, so all of these things kind of line up together. And tamponade is a very interesting case. It's a medical emergency, so how do we kind of fix it? So one thing to do is to fix the tamponade itself, right? So pericardiocentesis is probably your primary mechanism, and that's just, draining the pericardial space and releasing that pressure on the heart. So pericardiocentesis is a good one to think of, and this is just by inserting a needle into the pericardial space with ultrasound, and you're aiming just under the xiphoid process, and that will drain the fluid out and release that pressure. And that's one way to manage a tamponade. And then there's this other mechanism where really severe tamponades or malignant ones, you can create a pericardial window, and that is the excision in the portion of the pericardium that allows continuous drainage of the fluid that's built up either into the peritoneum or into the thorax, and then you can kind of drain via chest tubes instead of directly puncturing the pericardium itself. Again, we said that STEMI can be an antecedent, so the concept of time is muscle is really big. So delayed presentation to emergency with a STEMI leaves risk for many different complications, in which ventricular free wall rupture and cardiac tamponade are just some. So that's just something to keep in mind. STEMI, but your mainstay is going to be PCI, percutaneous coronary intervention, and that's going to be, you're going to get a stent in to reopen and the coronary arteries and revascularize the heart muscle. And then, your blood thinners, aspirin, antiplatelet agents, anything that's going to help regain perfusion and prevent any more muscle death is going to be pretty key in your STEMI treatment. And then there's surgical management, right? This is the Cardiovascular Society. So this is a really interesting case because there is surgical management both in your tamponade, and also you can have surgical management of your STEMI. If you get the left ventricular free wall rupture, you're going to need cardiothoracic surgery to call in and to remove any necrotic tissue, and then to start to kind of patch up where the hole has been left there. So those are some high level, kind of 3 levels of intervention where we can treat either the initial presentation or subsequent complications that may lead you to a tamponade. So quick takeaways: cardiac tamponade, you're gonna have a history with Beck's triad, hypotension, muffled heart sounds, and raised JVP, and then your ECG is going to show those electric alternans, which is caused by the swinging of the heart, and you'll just see that kind of varied amplitude in QRS with each beat. There's many causes, right? We talked about massive pericardial effusions, but ventricular free wall rupture is one that can happen if you have a delayed presentation from a STEMI, or a STEMI that you don't get revascularization or catheterization in time. So those are the things to look for in your takeaways. And of course, again, in addition to your ECG, your history and your exam are going to be really crucial in identifying this particular pathology. So that's it for another ECG of the week. Tune in for more interesting cases, and if you need a refresher at any time, have a look back at our YouTube page where you'll find lots of other ECGs and our introductory video.